Good evening, everyone. Glad to be here to talk on this topic. These are my disclosures. So what I thought I would do is just provide a bit of an update as to where we are in terms of ctDNA and IO response monitoring. I'll present on some of the data that we saw in ASCO this year, as well as a publication that came right after that I'm including in this umbrella. And then I'll talk about some of the implications of this work and kind of where the field needs to go before turning to the cases that you all submitted for the interactive portion. So I think everybody is kind of most familiar with ctDNA as a way of non-invasive mutational profiling. And this, of course, is very relevant to selecting targeted therapies, but there's less of a clear application of ctDNA in immunotherapy. The first attempt to kind of leverage this technology in the IO space was by using ctDNA to measure TMB. And so the earliest ctDNA in literature for lung cancer was validating that blood TMB was pretty concordant with tissue TMB, and that we had a similar response association as we had seen in the prior literature, where a higher blood TMB associates with a higher likelihood of IO response. But I would say in the years since these initial publications, there's been less of a focus on this, in part because the field has kind of moved on from TMB as an immunotherapy predictor. And we're more interested now in using a different aspect of ctDNA, which is as a way of detecting residual disease and as a way of on-treatment or post-treatment response assessment and monitoring. I think the best kind of proof of principle demonstration of this use case was a publication that came out of Max Dean's lab in 2020. And in this study, they took patients who had been treated with definitive chemoradiation. Half of them got post-treatment immunotherapy and half did not. All of them had ctDNA drawn at the time of their completion of therapy. And they use this as a framework to look at kind of the likelihood of disease recurrence and the benefit of additional immunotherapy. And what they found is that in patients who did not have any detectable ctDNA after radiation, there was actually no benefit to further immunotherapy, consistent with the idea that these were patients who were cured. And you can see that, in fact, the immunotherapy treated arm, which is this blue one, looks kind of subjectively a little bit worse, even though the p-value is not significant. In patients who did have detectable ctDNA after treatment, there was a benefit from consolidation immunotherapy with a p-value of 0.04. And then they also looked at ctDNA on immunotherapy. And what they found is that in patients where the ctDNA levels were going up, there was no benefit to immunotherapy, consistent with the idea that these are patients who are not responding to immunotherapy and have no incremental benefit from getting that treatment versus not. So this was a very important kind of proof of principle paper in an earlier stage setting. A lot of the studies in the advanced or metastatic stage have focused on demonstrating an association between ctDNA changes and immunotherapy response. One of the earliest studies in this aspect came from Yale in 2018, and they looked in a retrospective patient cohort and showed that patients who had a decrease in their ctDNA with these red boxes also had radiographic shrinking of their tumors. A similar study from the Dana-Farber also demonstrated very concordant results with a decrease in ctDNA associating with a decrease in the size of their target lesions and a higher likelihood of radiographic response. And here you can see kind of what these dynamics look like over time. So patients with CR/PR almost all have a decrease in their ctDNA levels. Patients with progressive disease almost all have an increase. And the stable disease is kind of split, where some of them have a pretty marked decrease and some of them have a pretty marked increase. And what you can also see from these figures are that a lot of these changes start to take place as early as at the end of the first cycle at 21 days. And so here you can see that in the patients who have response, their ctDNA response actually anticipates when they were first scanned. So this can be an early on-treatment signal. So with this background in mind, I think this kind of sets the stage for the idea that we can look at ctDNA on immunotherapy. And there are a couple of studies at ASCO and since that have built on this. So the two poster presentations that I wanted to discuss, these were two studies that looked at data from randomized clinical trials, so kind of nice, clean trial data. And that included patients who were treated with immunotherapy, but also patients treated on the chemotherapy control arm. So this allows us to look at ctDNA dynamics on immunotherapy as well as on chemotherapy. The other kind of novel aspect of these studies is that these used tumor-informed ctDNA assays. Most of the prior studies used off-the-shelf panels, which have a little bit of a less sensitivity. And then these studies also looked at ctDNA at multiple time points to kind of give you a sense of those dynamics. So the first study is a collaboration between myself and Regeneron using the Empower Lung 1 data set. This was a clinical trial that compared cemiplimab versus chemotherapy in PD-L1 high patients. And here you can see the cohorts and the ctDNA levels in both treatment arms. There are 87 cemiplimab treated patients and 91 chemo. You can see that at baseline, essentially all patients in both arms had detectable ctDNA, which is a testament to the increased sensitivity of this kind of tumor-informed assay. And then if you look at how ctDNA levels change over time, in the cemiplimab arm, you can see that at week 3, we already are starting to have a bimodal spread where some set of patients have an increase and then the rest have decreases. And by week 9, this very clearly segregates into patients who have ctDNA that's either going up or essentially almost completely clearing, with very few in this middle ground here by week 9. In the chemotherapy arm, you can see that actually most patients have a decrease in their ctDNA. There's far fewer patients who have a frank increase, but there also isn't this clear spread towards the lower level. And instead, there's a larger percentage of 30% and higher that are still in this middle zone. This tracks with the radiographic response. And again, it tracks very clearly in the cemiplimab group. Patients with CRPR, which is shown in blue, almost all have decrease in their ctDNA of 90% or greater. Patients with progressive disease, almost all have an increase. And then the stable disease patients are split with some going up and some going down. In the chemo group, again, the association is not as clear. And interestingly, the progressive disease patients actually had a decrease in their ctDNA. And so when we look at how these patients do, the ctDNA dynamics are a very good predictor of response in the cemiplimab group, but not as clearly in the chemo group. And I think what's interesting about the cemiplimab group is that at week 3, you can see that patients who have a 90% clearance or complete clearance do very, very well. At week 9, it's really that complete clearance group that does the best. And I think what's happening is that some of these patients who are in the 90 to 100% range at week 3 go on to clear completely by week 9. If you haven't cleared completely by week 9, that starts to be a less positive sign. And of course, patients who go up are the ones who do the worst. Now, in the chemo group, complete clearance is still very clearly associated with a good outcome, but all of the other groups actually don't as clearly track. And even patients with a 90% clearance seem to do as badly as the patients with increase in ctDNA. So, the inference from this is that you can take a combination of radiographic response and ctDNA levels and kind of give yourself a little bit more granularity as to how these patients are going to do. And indeed, the patients who have concordant radiographic response plus deep clearance of their ctDNA do very well. Patients who have concordant increase in their ctDNA and increase in their lesions do very badly. And if you take the patients who have stable disease or progressive disease, but have decrease in their ctDNA, you can kind of pull those better performing patients out from the overall group. So I think this tells us that there's a possibility to use this to identify early on patients who may not be benefiting from immunotherapy alone, in whom we could then add additional treatment. If you're starting with cemiplimab alone or pembrolizumab alone, you could add chemo. But it doesn't tell us how to interpret patients who are getting chemo plus immunotherapy. So the second study that I think is of relevance that was presented at ASCO this year uses data from Empower 131. And this compared patients who were treated with atezolizumab plus chemo versus chemo alone. with kind of comparable numbers of 117 and 104 in both arms. Here you can see their ctDNA levels and the dynamics across the different treatment cycles. Here again, this was a tumor-informed assay, and almost all patients have detectable levels at baseline. You can see that at the time of the second cycle, almost all patients had a decrease in their ctDNA. And then as we move forward through the different cycles, there starts to be a growing proportion of patients with an increase in their ctDNA, consistent with a group of patients that are starting to lose their response. When we look at the ctDNA waterfall plot, you can see that in both the chemo IO and in the chemo arm, the majority of patients have a marked decrease in their ctDNA, and this includes some of the patients who have progressive disease, though notably there are very few. And if we compare what we see here to what we had seen in the previous study, to my eye, this waterfall plot looks a lot like what we see with the chemo group, rather than the kind of more bimodal immunotherapy group, suggesting that in this chemo IO group, we're kind of blurring the IO signal with the chemo signal. But, there's still long-term benefit that some of these patients are going to have from the immunotherapy group, and that is reflected in the ctDNA. And so you can see that irrespective of how they define ctDNA changes, they looked at decrease, greater than 50% decrease in full clearance. That group is the group that associates with better PFS and also kind of markedly better overall survival. They also looked at whether this could help with decision-making. So they showed here on the left that in patients who had lost their ctDNA, who had cleared, that this might be the group where you would continue the immunotherapy, with the idea being that they had benefited. Conversely, if you hadn't lost the ctDNA, there was no benefit to adding an additional 2 cycles of chemo to go from 4 to 6 cycles, which is consistent with the idea that if they haven't cleared or benefited by that point, additional chemotherapy wasn't going to make a difference. And then the last study that I wanted to touch on, this was not presented at ASCO, but was published just 2 weeks ago in the New England Journal. So I think was relevant to the topic and also relates to the cases that were submitted. So this is data from the Nadim study. This study took patients who had surgically resectable stage 3 disease. Patients were treated with neoadjuvant chemo plus nivo, or were randomized to chemo plus nivo versus chemo. And then patients who at the time of surgery had an R0 resection, who had been on the chemo IO arm, got an additional 6 months of immunotherapy. And I think there are a couple interesting points from this. So in general, this was a positive trial, as we would expect, with a benefit from immunotherapy and increased PAT-CR rate. But one of the interesting things that they looked at is whether patients in this R0 group benefited from receiving additional immunotherapy. And they compared patients who received the full 6 months of immunotherapy versus patients who had to stop. And you can see that the full 6-month group, which is the red line, seemed to benefit compared to the ones who got less immunotherapy. And this was true even if they excluded the PAT-CR patients. So even patients who hadn't fully cleared their tumor at the time of their surgery benefited from an additional 6 months of therapy. Now, since this is a ctDNA talk, of course, one of the questions you would ask is, what about patients who had residual ctDNA after their surgery? Unfortunately, we don't have that data and they haven't presented it. The only ctDNA that they presented was looking at baseline ctDNA levels. On the left, you can see outcomes based on stage 3 versus stage 3A versus stage 3B had very different outcomes, with worse outcomes in the 3B group. And then they then looked at patients with detectable ctDNA versus not. And patients with detectable ctDNA at baseline also did worse. So the kind of implicit argument here is that baseline ctDNA can be as poor a prognostic factor as a higher stage. So, I think some of the things we've learned, ctDNA dynamics as early as week 3 can reflect radiographic response and can, I think, be used to identify patients who are not benefiting from the current therapy. ctDNA dynamics associate less tightly to outcome in chemotherapy treated patients, but Despite this, even with that caveat, ctDNA decrease is a favorable feature in these in the chemo-IO group. Using these more sensitive assays, ctDNA is detectable in almost all patients in the metastatic context, but how we would apply this in real-time practice is unclear, and it's something we can talk about. And I think a lot of the interest is in studying this in the earlier stage setting, post-surgery or post-chemo RT. We have a lot of neoadjuvant trials that have had outcome data read out, and I think we will see a lot more data on ctDNA as a surrogate for path-CR or in concordance with path-CR, but we just haven't seen a lot of those studies. So I think some of the questions going forward are going to relate to timing. When is the best time on treatment to assess ctDNA? What is our ctDNA threshold that we're going to use? Is it complete clearance or simply a decrease? How important is it to use one of these very sensitive assays versus an off-the-shelf assay? Are we going to use it as a way to de-escalate our therapy or to intensify? And then how will we kind of translate this to our decision-making in the early stage setting? So with that, I can stop this aspect of the presentation. And I'll pull up the case discussion. And in the meantime, are there any questions or comments about what I've said so far?
Yeah, I had a question. Which companies or labs do you use to check for these ctDNAs? What do you recommend?
So for these tumor-informed assays, most of the studies have used either the Foundation one or the Natera assay. The study that we presented had a mix of the Natera and the Foundation one. The problem with the tumor-informed assay is you first have to do your tissue profiling, and then they make the panel for you. So I think the applicability of that to real-time practice depends on how quickly you can get the tissue-based sequencing turned around. I think in the early stage setting, that's very doable because you have your biopsy, they get neoadjuvant, and then you have it ready to go. In the metastatic setting, that's much harder. And I think in the metastatic setting, you can probably get pretty good bang for your buck with just an off-the-shelf like a Guardant or Caris is coming, Tempus, stuff like that.
You said Tempus is, they have an MRD test or?
No, but I think Caris, I know, is developing just their ctDNA test. And I think Tempus has a blood assay, and then Foundation has an off-the-shelf, and then also their tumor-informed.
So NeoGenomics was just here in the office the other day, and they have one that they're providing as well, trying to, actually for no cost for now, at least, until they get more, on their usage, and then they start charging. But for now, yeah, NeoGenomics also has one.
Yeah, and there's different technologies too. So the tissue-informed one increases sensitivity by knowing something about the tumor. Some of the other companies are working on methylation-based assays. Guardant has one like that. It's the Omni assay, I believe it's called. And those can increase sensitivity just by virtue of including the methylation, but may not add time through that two-step process.
So that's Guardant Reveal, right? Is that the name of their test?
I don't know. I don't remember. I thought it was the Omni, but to be honest, I'm terrible at remembering.
It actually is the Guardant Reveal, but my understanding is they're retooling it because of the low sensitivity.
Okay.
Yeah, I think they have two methylation ones. Oh, maybe I'm thinking of the Archer. There's an Archer one too.
Yeah, because I do a lot of these talks in colon cancer, and the Reveal assay is used fairly widely there, and the sensitivity just isn't the same as the tumor-informed products. And I know Guardant was going back and actually redoing it because Duke, for example, stopped using it.
Yeah.
The other thing, I don't know about Foundation, but I know with Signatera that I know Medicare covers the test now for immunotherapy monitoring.
Yeah, we at MD Anderson, we do our own in-house panel, which is essentially a Guardant lookalike, but is not particularly sensitive. So we don't have a lot of the logistics in place to do this. But whenever I've ordered it, even with just our off-the-shelf, I've actually always gotten it approved. But I think that is a concern with doing doing this in a kind of routine way. So I think, you know, if there is some approval for that kind of stuff, it'll be nice because it'll actually allow us to get some more experience with these kinds of decisions.
I'm curious, you mentioned that the fairly high level of sensitivity and specificity with lung, but when we use the test in colon and other diseases, lung is often one of the low shedding sites that you can miss lesions. I'm curious if you think there's a difference between a primary lung cancer and a metastatic cancer.
Yeah, we see definitely big changes in sensitivity with stage. So having metastatic lung cancer and having certain metastatic sites, in particular bony metastases, associates with a higher degree of shed. And so one logistic issue that's coming for lung cancer doctors as we have more of the neoadjuvant therapies getting approved is how we can quickly exclude patients with EGFR and ALK mutations. And in the metastatic setting, we tend to just do ctDNA, but the sensitivity of that in the early stage setting is not high enough, probably, at least as it stands.
Is there a difference in sensitivity for different histologies?
Not that I'm aware of. I think the biological differences are probably confounded by the fact that adenocarcinoma is enriched for mutations that would be on that panel, on the panels, with the exception of like P53 and SMARCA4 and others. So you might have a higher predisposition to detect the adenocarcinomas, with the caveat in the other direction being that squamous are more heavily mutated.
Okay, if there aren't additional questions, let's go ahead and pull up the cases. I know one of the docs that submitted the case is not on the call, which is must have got caught in clinic, but.
Okay, so this was the first case.
Dr. Rudolph is on the call.
Yeah, did you want to present your case?
Yeah, sure, I'm happy to do it. So he's a 62-year-old African-American gentleman, smoker who quit smoking shortly after diagnosis of his stage 2B squamous cell, 4.9 centimeter tumor or initial PET. He was again stage 2B with some hilar lymph nodes. He was treated with neoadjuvant chemoimmunotherapy with carbotaxol nivolumab for 3 cycles. Had a PET post-treatment, and it was had shrunk down to 3.5 centimeter tumor. But oddly enough, this was more PET avid. SUV was 16 on a follow-up after neoadjuvant versus 15 initially. The lymph nodes were no longer PET avid. There was no disease elsewhere. One important sort of anecdotal point here, the surgeon actually wanted to do the surgery a good 2.5 months out. I know on the clinical trials that insisted on or had done the surgery within 6 weeks, but regardless, after back and forth conversation, he ended up having the surgery about 2 months later, and surprisingly, his tumor had increased. Of course, this could be a scan sensitivity issue perhaps, but it was 6.8 centimeters, so almost double the size of the scan, and 1 positive lymph node. So clearly that positive lymph node was a hilar lymph node. So clearly he did not respond to chemotherapy. Perhaps this grew maybe in that 2-month wait period, which I would be hard pressed to think. His NGS panel didn't really show much. FGFR1 gain was about all he had, but nothing actionable. The question really is what to do at this point. You know, the clinical trial allows you to do more treatment if needed, but I'd love to know your thoughts and how to incorporate ctDNA at this point.
And I gather that there was no preoperative scan.
That was the post-treatment PET was the preoperative scan.
Okay, so nothing after that 2-month recovery.
Correct. So he's just had, yeah. So that 2-month wait period right before surgeries when he had that that's when he had the post-treatment PET. So it was within a couple, 3 weeks of surgery.
Okay. So I'd be interested to hear what the rest of the group thinks in this situation. If people
Well,
haven't,
the SUV 16 versus 15, I'm not really toward post-treatment, a little worse, but I would say the response in the size is, more encouraging. But then 2 months later, it doubled, almost doubled when it's post-surgical specimen. That's disappointing. Maybe it's from the delay in surgery, definitely aggressive tumor progression during that delay in surgery. So, I mean, I don't know if I would really. So ctDNA, there was no baseline, right? I mean, you guys didn't do.
I have not used ctDNA in lung yet.
I mean, I haven't either, but for metastatic disease, I have. I haven't in this setting with stage 2, neoadjuvant or adjuvant treatment. So PET CT, did you look restage again with PET CT post-op?
No, he's not back to me yet after surgery. So this is hot off the OR.
Yeah. I mean, I would restage, see if there's any distant mets now. But outside of that, I would hope that there's not, and then just plan for adjuvant treatment. Is just, what are you going to give? I don't think I wouldn't say they failed immunotherapy. I mean,
I know. I think it failed. Yeah, the tumor grew.
Okay.
The tumor grew. I mean, I don't know if you knew about the status of the nodes prior to surgery. Histologically speaking, proven or not, but the tumor grew, so it's resistant. And to utilize adjuvant chemotherapy here, I don't see much of a reason to do so if he failed to, the 3 cycles of chemo. I would just monitor this patient and use an alternative therapy if he shows signs of progression.
So I think that this is a great case where we will eventually have data about the use of ctDNA and its association with outcome. I think there's 2 separate questions. One is, can we prognosticate about how he's going to do? And then the second is, can we make his outcome better? And I think for the ctDNA piece of it, you probably could get some good prognostic information. I think, we know that the patients who have the best outcomes after neoadjuvant therapy are those with path CR. He obviously does not have a path CR, but your degree of worry could be informed by the ctDNA. I think the next question is, let's say you can't get ctDNA or it comes back positive. What do you do? I think that's very hard. Historically means the last 3 to 6 months since we've kind of had these regimens at our disposal. For patients who have not done as well as I have wanted on their neoadjuvant therapy, I have also observed, simply because it seemed to me like the likelihood of further benefit from additional chemo or immunotherapy was low. I do think that the results of the Nadine trial that I presented at the end are somewhat thought-provoking insofar as it suggests that even in patients who didn't completely clear, there may be some additional immunotherapy benefit. So that might be the one thing that I would consider doing, would be some additional immunotherapy. I think in this case, it's harder to justify that because he is a PD-L1 negative tumor. So there's another strike against you and kind of hoping for any immunotherapy efficacy. But if you have positive ctDNA and there's no visible disease on the PET scan, then, arguably you could try that just to feel like you had done everything. But in my practice prior to this, I have tended to just observe and kind of watch and worry about them.
Yeah, so if I were to do additional Nevo, so would you switch immunotherapy and for how many cycles?
I think, for insurance reasons, you could argue that Pembro is the best fit in this case because it's PD-L1 negative and you're kind of treating in an adjuvant setting. And, maybe there's some data for that. I would, plan on 6 to 12 months, I suppose, if the patient is doing well. But, in this a situation like this, where you have a very low likelihood of any real benefit, then I tend to err on the side of pulling off and letting the disease declare itself and then dealing with it when it comes back.
If the ctDNA is positive, would you do anything different?
So I think if the ctDNA is, sorry, had you just asked if the ctDNA was negative? If the ctDNA is negative and your PET scan is negative, you might be okay doing nothing. If your ctDNA is positive and your PET scan is negative, then I would treat with Pembro.
Gotcha.
And the other thing that you could do, if again, we're kind of assuming insurance lets us do whatever we want, is you could test the ctDNA with your surveillance scans. Because that's the other data that we have, right? Is that when you're on treatment and you're seeing the ctDNA go up, that at least gives you a justification to pull it off, since you know that it's not working.
So I'm curious, if you discuss with the patient and you make the commitment to give adjuvant Pembro, why wouldn't you use ctDNA then? Because if the ctDNA is going up on the Pembro, why would you expose them?
Yeah, I would.
Good point.
Yeah.
And it would certainly, excuse me, allow us to prepare them for badness, I guess. So, as far as waiting for the ctDNA, what's your turnaround time for that? I've certainly struggled with Signatera, having a good 6 weeks and sometimes not having done the pre-op ctDNA.
Yeah. Sorry, I think I froze for a second. So our off-the-shelf ctDNA is very fast. It's 1 to 2 weeks. For these tumor bespoke ones, I haven't personally ordered them, but I know that the reality is that they can be a number of weeks. And I, for all of this kind of testing, basically try to get it cooking as soon as I can. So if you can do it off their pre-treatment biopsy and get that started, then you can do that during your neoadjuvant therapy. You can also do it right at the time of surgery, and then that gives you, let's say, 4 to 6 weeks to then start your adjuvant therapy, which is not terrible in terms of a kind of a post-operative delay.
Yeah.
I see that this is going to be more useful not in the metastatic setting, because if you get still a negative ctDNA after a couple of rounds of treatment or whatever you decide, 9 weeks, and the patient still has positive ctDNA, are you going to change the therapy based on that if clinically they are doing well? If they are either responding, by scans, or they are doing better, whatever symptomatology they had is improved, the pain is improved. I think the use would be great in this scenario here, of neoadjuvant treatment or decisions about adjuvant treatment in situations where you're not too sure if the patient should receive or not. In this particular patient, you just showed us that the ctDNA dropped significantly with chemotherapy, at least to a certain level. So doing now, and you had not done it prior to the chemotherapy, is going to be very hard to interpret it, because if it's negative, is it because he received the chemotherapy and now we have a low level or an undetectable level because of that? And yet the patient had progressed based on anatomical data.
Yeah, I mean, it's
So I
hard to
would,
know all of the time points for this. You know, my impression with the chemo is that you probably get a transient drop in ctDNA, but I suspect at this time point in somebody's care when they've been off treatment for a couple of months, if you have tumor progression, that you would probably see detectable ctDNA. I think to your point, you know, to kind of the broader point you were making at the beginning, to my mind, the application of ctDNA is any context in which your scans are not either accurate or kind of sensitive enough to allow you to make the most important treatment decisions. So that's certainly the case in post definitive therapy when you're looking for minimal residual disease or microscopic disease. I think in the metastatic setting, logistic issues aside, I certainly have a lot of patients where I have equivocal scans. And, you know, obviously, if they're doing well clinically, that's great, but plenty of patients are also doing kind of equivocally. And you don't know, is it the treatment? Is it the tumor? You see some lesions go down, you see a couple go up a little bit, maybe some lymph nodes are bigger, but it's all within the range of kind of, you know, stable disease or something in the margin. And in that situation, I would certainly welcome seeing somebody ctDNA clear, for example, like that would be very helpful. So, and I think the other situation where you could imagine using it would be if you started on immunotherapy monotherapy, and then you saw the ctDNA go up, then that would be a context in which you could add chemo. I think part of the problem with ctDNA-based decision-making right now is that we just don't have that many additional treatment options to deploy. So getting the information from the ctDNA is nice, but it doesn't allow us to change our therapy because we are already using our best drugs. But if we have other ways we can combine therapy or other agents to add, then there may be an additional use case for it in these different treatment contexts.
Looking at this, excuse me, case retrospectively, so, you know, the fact that his SUV went up, of course, it's not the best test, but could we have spared him surgery? Maybe we should have switched his chemo and given him radiation, realizing this is maybe not curable. What are your thoughts? Have you run into such situations?
Well, I don't think that you know that you haven't cured him right now. I think, you know, I think these situations, the question is, should he have gotten surgery sooner? Or should he have gotten his definitive therapy, whatever he was eligible for, sooner? Rather than kind of pressing on with a therapy that maybe wasn't working. And that I think is hard to know. But if the surgery was a good surgery, he had clean margins, he had a resected node, then I'm not sure with a 6.8 centimeter tumor that wasn't even fully captured on imaging that the radiation would have done better for you.
Yeah.
So we have one more case.
Actually, I think what I'm going to do is, I think he got caught in clinic and he'll probably join us next week.
Okay.
So, and I don't think it's going to really change the conversation a whole lot than we just had. So let's go ahead and just keep that for Dr. G when he can participate next week.
Okay.
Does anybody have any additional questions they'd like to ask?
I have a question. Priya, the PD-L1 on this patient was what? I missed that part.
It was negative.
So is it not on a Nadim trial, the PD-L1 had to be more than 1 to be put on immunotherapy?
It's a good point. For the Nadim trial, I'm not sure if they specified. For adjuvant atezo, they did, but I actually had it open, so I can take a look. But you can give adjuvant pembro, for sure, irrespective of PD-L1.
Yeah, sure.
Yeah, it works no better in high PD-L1.
Yeah, I mean, I think that's the issue, right? I think you can find a way to give immunotherapy in this patient. All of the data would suggest that he's probably not likely to benefit, and his path response would also go along with that. But if you feel pressed to do something, I think that would be the move. I probably wouldn't give him more chemo. But I think the ctDNA can titrate your level of worry. I think if you have negative ctDNA, you can feel more comfortable watching.
Yeah.
Any other questions? I'm just looking up the Nadine trial right now.
Are you using this routinely in your practice? We are in an era of cost containments. So are you using the ctDNA and metastatic lung cancer routinely?
So we use it for mutational profiling routinely because our tissue sequencing is very slow. So we can get the mutational profiling much faster through ctDNA. And in multiple ctDNA testing for response assessment, I don't routinely do because I do worry about my patients getting billed and not getting reimbursed. I have sent this kind of MRD testing in a handful of patients. So I've had a couple of patients who've had treated disease and then had some equivocal findings on scans with negative biopsies, but kind of concerning PET scans. And in those patients, I have sent ctDNA to say as kind of a disease diagnostic companion. And in all cases, it's been very unhelpful because it's come back with a low level P53 mutation. So I have a low level P53, I have a negative biopsy, and I have equivocal PET. And in all of those situations, I have never found a surgeon willing to operate on that basis, nor have I been comfortable starting chemo for something like that. So I've now had to just watch those patients and see what happens. So I can't say that it's been very helpful for my practice, but I do find it kind of interesting to start to amass this data.
I'm fairly certain that both Guardant and Natera will not ask a patient to pay in this setting.
Yeah, I've had some of my patients get billed, but I'm not sure that they've gotten forced to pay. I think our best hope is that these neoadjuvant trials will report ctDNA. I think that a lot of them are drawing post-treatment blood, and we will see those studies come out. But the rest of this space is going to be on the basis of providers starting to do this and monitoring outcomes and then reporting, because the rest of it is going to be this kind of aggregating practice experience. I think the only other way we'll ever get trial data to support this would be if a company runs an intensification trial. So if they start patients on single agent immunotherapy and then they randomize into a treatment patients who have increasing ctDNA after 2 cycles, something like that.
I would think that the companies would want to do de-escalation trials as well to make a cost argument to the payer.
I don't think companies
Well, Regeneron's not going to do it, but Gardner
our cost is
might.
their money.
Because that's really the great value proposition for the testing companies, is to show that they can actually save the payer money and avoid toxicities in patients that don't benefit from the treatment.
Yeah, I think it's hard though, because in the chemo IO context, if your ctDNA is going down, I'm not sure that tells you very much. For the data that I showed, you know, I think,
I agree. I just think if it's going up.
yeah, but if it's going up, you know, as Dr. Jayab, I'm not sure what your name is, but that's your Zoom name, as you said. I mean, I think it depends on how well your patient is doing. If your patient isn't doing badly and your scans are stable, it's hard to justify stopping that therapy just on the basis of ctDNA. Because we just don't have that many moves. I think if we had 20 great drugs to choose from, then we would be welcome additional mobility on the basis of ctDNA. I can stop sharing and see everybody a little bit there.
So we didn't find if it was the PDL1 on the
Yeah, in the abstract, they don't mention PDL1. And on a lot of the chemo IO trials, they don't specify PDL1. So my impression had been that it was PDL1 agnostic, but I apologize if I'm misremembering that.
Yeah, well, I think we can go ahead and wrap it up then, unless anybody has a last question they'd like to ask. If not, thanks everybody for taking some time out of your evenings tonight. Thank you, Dr. Vokes, for an excellent presentation and discussion. And until we meet again, everybody enjoy the summer.
Thank you.
Okay,
Thank
take
you.
care.
Thank you,
Good
Charles.
night. Thanks.
Thank you. Bye.